Dear listeners, we are happy that you are interested in the application possibilities of the electrical stimulation in the clinical practice of physiotherapy. All the information of the slides was prepared during the implementation of the European Union funded Erasmus Plus project called Clinical K for Electrical Stimulation. The leading partner of this project is Pamukkale University from Turkey. Other partners from Turkey are Mustafa Kemal University, Başkent University, Süleyman Demirel University, Budur Mehmet Akif Eroğlu University. Also, we have partners from Romania, University of Craiova, and Lithuania, Šiauliai State University of Applied Science. In this project, also participating the Turkey, Romania, Lithuania, and Estonia physiotherapy associations. I want to introduce with the Model 3 electrical stimulation for healthy muscles, and this model subtopic 3.6 electrical stimulation for patients with orthopedic problems. This subtopic was made by physiotherapists Dovydas Gedrimas and Vaida Aleknavičiūtė Ablonskė. In this subtopic, we will talk about common orthopedic problems, which are lateral epicondylitis, joint pain, spine pain, including back pain and neck pain. Lateral epicondylitis is common as it affects 1–3% of the population. Non-operative treatment represents first-line therapy and may include no active treatment, strengthening, extracorporeal shock wave therapy, transcutaneous electrical nerve stimulation, and injections of the corticosteroid, platelet-rich plasma, and autologous blood. Surgery may be considered when non-operative treatment fails. Pain from lateral epicondylitis usually initiates after repetitive or excessive extension of the wrist during supination. Lateral epicondylitis is characterized by continuous light traumatic symptoms at the humeroradial joint and gradual increases in such symptoms. Missing early treatments leads to a decrease in muscular strength. Pain is one of the problems experienced by patients and can be potentially accompanied by physical, physiological, or physiosociological disabilities. Pain management for lateral epicondylitis. Electrical stimulation for pain control is always a good choice for pain reduction in epicondylitis cases. No significant difference is found in pain between high-frequency and low-frequency transcutaneous electrical nerve stimulation. Physiotherapists can use either one of these suggested stimulating settings, which are shown in the table. If we decide to use high-ray transcutaneous electrical nerve stimulation, the frequency should be more than 100 Hz. Pulse duration is recommended 50 to 80 microseconds. Intensity in milliamperes, it should be till tingling sensation. Treatment time may be used as long as need. If we decided to manage the pain for lateral epicondylitis using the low-rate transcutaneous electrical nerve stimulation, frequency should be between 2 and 10 Hz. Pulse duration 150 to 300 microseconds. Intensity milliamperes should be till visible contraction. Treatment time 20–30 minutes. While we are talking about the pain management for lateral epicondylitis, in this slide you may see the example of electrodes placement for lateral epicondylitis. Electrodes are placed so that the electric current covers the area of pain. One electrode should be positioned above and the other below the pain site. During the electrical stimulation, patients should sit or lie in comfortable position and feel relaxed. Strengthening for lateral epicondylitis. For strengthening, a Faraday current can be used with these parameters. A frequency in the range of 30 to 50 Hz is commonly employed to induce muscle contractions. The pulse duration is usually set between 200 to 400 microseconds. The intensity of stimulus should be set to a level that effectively contracts the target muscles without causing discomfort or pain. It should be strong enough to generate the visible muscle contraction. Common duty cycles include one with 2 rate, stimulation on for 1 second, followed by 2 seconds off, or 1 with 4, stimulation on for 1 second, followed by 5 seconds off. Treatment time varies between 15 and 30 seconds. Joint pain, arthritis. Electrotherapy is commonly used in the physiotherapy and rehabilitation programs of patients with rheumatoid arthritis to relieve pain and improve function. Despite the widespread ongoing use of transcutaneous electrical nerve stimulation by physiotherapists and people with several conditions including rheumatoid arthritis for the control of pain, the application of this treatment modality in clinic is largely based on empiric evidence. Transcutaneous electrical nerve stimulation is suggested as a potential therapy for the treatment of musculoskeletal conditions in American Physical Therapy Association guidelines. The Arthritis Society also recommends to use the transcutaneous electrical nerve stimulation for pain and joint swelling in people with rheumatoid arthritis. Transcutaneous electrical nerve stimulation has been demonstrated to be effective for chronic pain lasting over 3 months. Various modes of transcutaneous electrical nerve stimulation device settings have different stimulation parameters and are thought to have certain biological mechanisms for their analgesic effect. In systematic review, it was suggested that when strong burst mode transcutaneous electrical nerve stimulation was used for 6 weeks, pain relief improves considerably compared to placebo transcutaneous electrical nerve stimulation. Also, it was found that acupuncture-like transcutaneous electrical nerve stimulation had more rapid effect as pain was reduced at the end of the 2 weeks treatment period. However, if the treatment duration was less than 2 weeks, transcutaneous electrical nerve stimulation did not demonstrate a significant difference in pain relief compared to placebo, which may suggest that the effect of transcutaneous electrical nerve stimulation applied in any mode are cumulative and required at least 2 or 6 weeks of use for a significant clinical reduction in pain to the experience. Joint pain. Transcutaneous electrical nerve stimulation is a widely used form of electroanalgesia, with the existence of many clinical reports and studies concerning its use. Transcutaneous electrical nerve stimulation is thought to produce analgesia according to the gate control theory. The electrical stimuli delivered by transcutaneous electrical nerve stimulation units can be varied to suit a patient's tolerance as well as to produce the best efficiency. Current amplitude, for example, can be set at low, medium, or high intensity for the comfort. Pulse width or duration from 10 to 1000 milliseconds, and frequency from 0.5 till 10 Hz for the high intensity and 80-100 impulses per second for lower intensity. The positioning of electrodes may also be important in electing analgesia. The placement of electrodes is dependent upon getting optimal stimulation from the mode of transcutaneous electrical nerve stimulation being used. According to the gate control theory approach, the stimulus from transcutaneous electrical stimulation must be transmitted into central nervous system. This transfer is enhanced by electrodes placement on optimal sites. They may, for example, be placed directly over the pain area, over cutaneous nerves, acupuncture points, or other trigger points. Another electrode placement site is over the dermatome zone, which is most closely related to the area of pain. If two or more of these entities are stimulated simultaneously due to specific placement of electrodes, then greater specificity of the application will be achieved. In this slide, you may see two examples of electrode placements in the knee joint pain, figure 2, and electrode placement for shoulder pain in figure 3. Electrodes can be applied around the joints using the longitudinal technique, both medial and lateral sides as shown in the knee joint. It is also possible to cross electrodes as shown with the shoulder, so that the electric current travels diagonally across the joint, and at the center of this current mass there is the strongest effect. Transcutaneous electrical stimulation has been demonstrated to be effective for chronic pain lasting over 3 months. Various models of transcutaneous electrical stimulation device settings have different stimulation parameters and are thought to have certain biological mechanisms for their analgesic effects. In systematic review, it was suggested that when strong burst mode transcutaneous electrical stimulation was used for 6 weeks, pain relief improved considerably compared to the placebo transcutaneous electrical nerve stimulation. Strengthening in joint pain cases. Not only transcutaneous electrical nerve stimulation, but also neuromuscular electrical stimulation can be used in cases of rheumatoid arthritis. Neuromuscular electrical stimulation has been shown to be safe and effective in improving quadriceps femoris muscle mass in different populations, including those with rheumatoid arthritis. The effectiveness of neuromuscular electrical stimulation seems to be intensity dependent. For example, higher intensities results in larger muscles improvement. The intensity of neuromuscular electrical stimulation training is defined as the magnitude for torque produced by the neuromuscular electrical stimulation elicited muscle contraction. Neuromuscular electrical stimulation training intensity is generally expressed as percentage of the torque produced compared with the patient's maximal voluntary isometric contraction. One drawback of neuromuscular electrical stimulation is that electrical stimuli produced during application can be uncomfortable. Hence, clinicians used increase the current intensity based on a patient's tolerance, which might not reflect the necessary training intensity required to improve muscle mass or strength. Currently, information of the neuromuscular electrical stimulation current intensity necessary to effectively produce changes in muscle mass or strength in skier, and studies investigate the effect of neuromuscular electrical stimulation on muscle's quality. Amount of fat accumulated with the muscle are lacking. In the rheumatoid arthritis cases, muscular stimulation with alternating symmetrical square waves can be used at the 40-100 Hz frequency when the pulse duration 300 microseconds, duration of stimuli 20 minutes in order to strengthen the muscles. On-off ratio can be 7 seconds with 23 seconds. Chronic low back pain. Chronic low back pain is a major common public health condition with a 12 months prevalence of 66% in women and 58% in men and a lifetime prevalence of 84%. This condition is also the lead cause of disability worldwide. It has been reported that various factors account for the development and/or maintenance of chronic low back pain. Additionally, patients with such condition are often accompanied by high treatment costs, sick leaves, and low quality of life. Muscle strengthening in low back pain cases. Patients with chronic low back pain are commonly prescribed stabilization exercise. Prescribing stabilization exercise is based on the rationale that chronic low back pain is associated with the motor control impairment and atrophy of the paraspinal muscles. These impairments presumably render the spinal muscle unable to produce sufficient activation to maintain spinal stability. However, stabilization exercises have only a small treatment effect in the short term, and their effectiveness has not been shown in the long term. Additionally, neuromuscular electrical stimulation can be used to obtain better results. The neuromuscular electrical stimulation electrodes can be applied bilaterally to the lumbar paraspinal muscles. A pillow should be placed under the abdomen of the prone lying patients. Two large 12 and 6 cm self-adhesive electrodes should be applied to the paraspinal muscles on the electrode on each side. The high-voltage pulse galvanic stimulation parameters are set to produce a pulse frequency of 75 Hz, a pulse duration of 250 microseconds with the 4 seconds ramp up and ramp down time, and a 6-second stimulation period at the maximum amplitude followed by 50 seconds rest period to minimize the fatigue. Patients should be instructed to perform active trunk extension as soon as they feel the electrical current ramp and to return to the resting position with the current ramp down. With this method combines active movement with neuromuscular electrical stimulation. Pain control in low back pain cases. For patients suffering from chronic low back pain without radicular pain, 4 electrodes should be placed on the healthy skin, 2 on each side and 2 on the painful area. The electrodes application must be the same as was described before. All the time, patients should lay down on the couch in prone position with a pillow beyond the pelvis. And the parameters which are used for patients with a chronic low back pain without radicular pain are recommended. Frequency 100 Hz, pulse width 200 microseconds, duration 20 minutes each time during the course of treatment. In this slide, you may see the electrode placement for lower back pain. As you see in the picture, 4 electrodes should be placed on the painful area. For those experiencing chronic lower back pain associated with radicular pain, 2 electrodes should be placed scanning the painful area of the back and 2 electrodes on the trajectory of the spreading pain area involved in radiculopathy. Stimulation may be continued for 1 hour a day. It is recommended for patients to complete 1-hour treatment session per day for a total of 3 months. In Figure 4, you may see the patient electrode placement without radicular pain. 4 electrodes should be placed on the healthy skin, 2 on each side of the painful area. Pain control in chronic neck pain cases. In this slide, you may see two examples how the electrode can be placed. In Figure 5, you may see the electrode placement for the neck pain. In Figure 6, electrode placement for the trapezius muscle pain. In order to treat neck pain, transcutaneous electrical nerve stimulation electrodes should be placed symmetrically in the upper cervical spine area of both sides. The recommended frequency of 100 Hz, pulse width of 250 microseconds, 20 minutes each time during the course of treatment. I will remember you, it's for the electrode placement for the neck pain, it's Figure 5. If pain is in trapezius muscle, Figure 6, electrodes should be placed along the muscle fibers. At least 10 sessions should be completed to obtain accumulative results. If using controversial TENS, parameters should be 60-100 Hz at sensory threshold for 20 minutes. If using burst TENS, the recommended parameters are 2-4 Hz for 30 minutes. If using modulation transcutaneous electrical nerve stimulation, parameters may be 100 Hz at motor threshold for 20 minutes. Usually, patients' pain reduces when applying high-frequency or low-frequency transcutaneous electrical nerve stimulation. So the clinicians should use parameters that are more suitable for each patient. Sometimes, when performing electrical stimulation, patients may feel discomfort despite the fact that those chosen frequency is correct and meet the recommendations. In these cases, a physiotherapist may adjust the pulse width. The longer pulse width may cause more irritation. This should especially be considered in acute phases of pain. So if 200 microseconds pulse duration causes discomfort or irritation, pulse width may be reduced to 50-150 microseconds. This adjustment should let the patient feel more gentle stimulation even if the intensity is higher than before, when pulse was, for example, 250 microseconds. Thank you for your attention. And there is the references of the all information and literature that was used preparing this subtopic. Thank you and have a good day.